This conference will now be recorded.
Welcome in, everybody. On today's lecture, we are going to be talking about Introduction to Emergency Medical Care. So our objectives for the day is we're going to be talking about EMS operations and systems as a whole, how they operate, and then we're also going to start to dive into the history of emergency medical services, more specifically in the United States. So when we're looking at EMS system and the history and implementation, EMS technically was first developed within the 1790s. And this is when France actually began to transport wounded soldiers away from the battlefield. So there was no type of pre-hospital care given. This was simply a transport unit. But this was the first example that we actually saw that individuals who were hurt and or sick were actually being transported by individuals. Fast forward to the Civil War era, this is actually the development and implementation of the American Red Cross. So Clara Barton was actually the founder, and this is where we first started to see soldiers being cared for while on the battlefield. Most of this had to do with stopping the bleed and wound management. But again, this is our first experience, especially in the United States, where individuals were getting treated on scene, and then they would actually be transported from the battlefield to medical tents. World War I, the Korean conflict, and then also World War II, we saw a drastic increase as far as emergency medical services within the military aspect. So World War I is when we first started seeing ambulance corps being transporting patients from the battlefield to medical tents. World War II, we saw an increase as far as training and education for individuals who are actually deemed um, medical personnel within the Army, Navy, what have you. Then we started to see a broadening as far as how these individuals were transported within the Korean conflict and the Vietnam War. So the show MASH was actually based on the first implementation of air care within emergency medical services, specifically correlating to the military aspect. Now, within this military aspect, this is still very prevalent today because where we take all of our trauma research from is actually from the military. So, because of the base of the military medical aspect, that transformed into how we operate today and how the first implementation of emergency medical services was incorporated into the civilian world within the United States. So within the early 1900s, this is where we first started to see non-military ambulance services providing service, and this was specific into major metropolitan areas. It didn't really correlate to the the rural areas at this time. Now, the capabilities of these individuals are simply show up to a sick or injured person, put them in the back of either a horse-drawn carriage or later on motorized vehicle, and then transport them to the hospital or an awaiting doctor. Now, over time, 20s, 30s, 40s, we started to see these individuals actually be trained as far as providing on-scene care. Most of these ambulances were actually operated by the morgues and morticians, so you could almost see a conflict of interest there. But then eventually they started to be city based on or hospital based on. Then 1966, this is really the grandfather and implementation of emergency medical services as a whole within the United States. Now, there was a lot of different spots and areas within the country that was improving their pre-hospital field, but the 1966 National Highway Safety Act really implemented EMS standards and provided resources and funding to the whole. So now areas that never had EMS services was able to get these services actually provided in their area. Now, this was all done based on a study of morbidity and mortality rates on the highways. So there was a ton of individuals who were losing their lives based on motor vehicle accidents And what they found out is if they could implement pre-hospital care for these individuals involved in this motor vehicle accident, then their chance of survival was substantially higher. So this was basically a blanket term, but then in the 1970s, this is the National Registry of Emergency Medical Technicians. They were founded and established, and they actually gave professional standards. So up until this point, a lot of ambulance services were running with individuals who were basically just trained in first aid. Now 1970 rolls around and they create this national standard as far as professional certifications, education, and licenses. Then 1973, this is the National Emergency Medical Services System Act. And again, this provided much more funding, operations, resources, education, guideline protocols in order to really develop EMS today. So looking at this history timeline too, it's easy to see, why is EMS kind of the redheaded stepchild of emergency services when comparing it to law enforcement, fire departments, and it's because we're such a new organization. So with fire departments and police departments, they go back hundreds and hundreds of years. Europe, Asia, even Africa had some type of implementation of those services, but EMS really just got started. I mean, we're basically an infant when we're looking at history. So there we can see this is Claire Barton. Again, she had established the American Red Cross, who first started providing that care for those wounded soldiers within the Civil War era. An example of World War I, this is actually a picture of the medical or ambulance corps. This is a picture depicted from the Vietnam War, and we can see that these individuals were actually advanced trained as far as providing interventions. We can see that this individual is actually getting an IV in the field, so this is pretty substantial care and implementation, because this is very similar to kind of what we do in the field now. And then as far as the civilian world, this is a picture depicting the Vancouver ambulance. This is their first ambulance that they had. This was owned and operated by the General Hospital in Vancouver, but we can see the basics of EMS starting here in the civilian world, where it was a load and go situation with that horse-drawn carriage. Fast forward to the 60s and 70s. This was a very common type of ambulance. You might recognize it from something like the Ghostbusters. This is where we were talking about individuals who are basically trained in first aid at that point. And then EMS today. So a lot of different new technology capabilities that are coming out. So this is an example of a heavy rescue ambulance service that can provide a multitude of rescue operations as well as EMS. Other EMS ambulances that are utilizing big rigs like this could be major metropolitan areas that have critical care ambulances. They might even have doctors and nurses that actually ride in the back of the ambulance. So EMS today, regulated and heavily governed by a couple of different agencies. First, we have the National Registry of EMTs. So this is a certification. So the National Registry actually depicts, okay, what standards as far as education that an individual needs in order to pass and be competent as an EMT. This doesn't necessarily allow them to practice. Then it is the state's job to actually regulate those policies and provide licenses. And your license is actually your right to practice. Resource management, much more implementation as far as management and operations is going in the EMS in comparison to what it used to be. There wasn't a lot of overshadow as far as how individuals were actually practicing out in the field. Human resources, training and education, and transportation, again, all envelop EMS. So with training, we mentioned certifications and licensure. So this is based on a 2-year time period. So every 2 years, you have to renew your certification and you have to renew your license.
This conference will now be recorded.
So as mentioned, training and education, this is done on a 2-year time period cycle in order to renew your certifications and your license. So this is governed by the National Registry of EMTs and then whatever state that you're actually practicing in. Now, most states have adopted the National Registry recommendations as far as education and training, but you need to put in a certain amount of hours and a certain amount of categories in order to go ahead and renew your license. Now with transport today, we're starting to see more and more capabilities, longer transport times in different capabilities. Now I mentioned air ambulances. This is a very common occurrence, especially in rural areas. Those are utilized quite a bit. And then also with inter-facility transports. Same thing with ground ambulances. They are providing more critical care aspects as far as transport, and then deeming it a little bit more necessary to go to the highest qualification of that hospital in comparison to driving them to the closest facility. So facilities and communications tie in together. Facilities, we're seeing more EMS organizations invest in higher capability facilities where they can provide education and training, and then also house proper sleeping quarters and living quarters for these individuals, because oftentimes EMS professionals are working 24 hours. And then with communications, we're going to talk about this a little bit more in detail when we look at communication and documentation. But communications, where we can talk to local agencies as far as first responders, talk to the hospitals, talk to our medical director, all with ease as far as our handheld and base radio systems. Public information and education, more and more EMS services are getting into this role as far as how can we improve community health in comparison to just being a retroactive organization where somebody gets hurt and then we respond, but looking at a broader scope of community service where we can actually prevent those injuries from occurring in the first place. And then medical direction. So just because you have a certification and a license, that doesn't mean that you are allowed to practice within whatever state that you have that license. We actually have the ability to practice because of a medical director. So for example, you are working for a local fire department. That fire department is going to have a medical director who is a licensed physician who's in charge of their EMS operations. Now we act, respond, and practice under that physician's license. So they approve protocols, they approve guidelines, they approve training, again, all in order for us to actually practice. So components of the EMS system, this is what we need in order to actually operate. First, we need a patient. So that patient is going to activate the 911 system, and then as a result, we have a duty to act to go ahead and respond to that patient and treat them within our protocols and our guidelines. With the 911 system, every county is going to have some type of 911 capabilities. So that individual on scene is going to call 911 and they're going to talk to that emergency medical dispatcher. So depending on the capabilities of that specific county system, they're going to be able to pinpoint exactly where they are on the planet with the enhanced 911 system. Other 911 systems, we can pinpoint where they are based on the closest cell phone tower that they activated. Other systems are still within the basic 911 system where they have to give a specific address of where that is. From there, it's a tiered response. So somebody calls 911 after a motor vehicle accident, that emergency medical dispatcher activates the 911 system, and oftentimes the first individuals who are going to show up on scene are going to be emergency medical responders. From there, we're going to get ambulance services depending on the area, whether it's a basic life support ambulance, which is going to be housed by EMTs, or an advanced life support ambulance, which is going to be housed by paramedics. From there, we're going to activate the transport system and actually bring that individual to the emergency department, where they're going to be cared and treated for by physicians and nurses, and then they might be bumped up to a higher level of care within that hospital, whether it's in the intensive care unit, cardiology unit, what have you. So here we can see an incident occurs, and any 911 call has a common denominator in which the individual has lost control of that scene. So this individual has lost control of their car, they got into a major accident, they can't care for themselves at this time, and that's why the 911 system is activated. Individual sees this, they're going to go ahead and activate the 911 system. Hopefully they can give a good picture of exactly what's going on. Based on what this individual tells dispatch, that is going to be the dispatch information that is then going to be relayed to us. So when we're responding, we have a rough idea of what we're responding to. So if we go back to this picture, hopefully they're going to be able to tell us that it is a one vehicle accident, and hopefully the number of patients that we actually have. Dispatcher is going to be able to receive that information, see who their closest units are to that scene, and then be able to dispatch the appropriate resources to that scene. So because it's a motor vehicle accident, oftentimes we're going to get law enforcement, fire departments, rescue units, what have you. First responders are going to arrive on scene, and they're going to provide that first initial patient care and scene mitigation. Scene safety is always the most important aspect whenever we're responding to an incident. Transport occurs, and this is the individual then in the emergency room having that continuous care. So accessing the 911 system, I went into pretty good detail about this. What I didn't touch on is the certification and licensure of the emergency medical dispatcher. So these are highly trained individuals. Oftentimes they can actually start giving recommendations as far as care to any bystanders on scene. So for example, if somebody's in cardiac arrest, most emergency medical dispatchers are going to be able to tell that bystander how to do chest compressions on that individual. This is the state of Minnesota. These are the counties where they actually have their own 911 center dispatch capabilities. So oftentimes, people's public service area is actually going to overlap a little bit. So what can happen, for example, Lake County Ambulance, which is located in Two Harbors, actually has some area within St. Louis County as their primary service area. So if a 911 call were to come in that portion of St. Louis County that Lake County covers, then it's going to come into the St. Louis County system and then get dispatched to Lake County Ambulance. So even though you might operate within a specific county, that doesn't mean that a different county can actually dispatch you. So then let's look at the different levels of EMS training. First, the base knowledge is going to be the emergency medical responder. Oftentimes, again, they are first on scene. Heavy emphasis on controlling major life-saving interventions, such as cardiac arrest management, controlling the scene, bleeding management, and airway intervention. Next, we have the emergency medical technician, minimum level of certification for ambulance personnel as of right now. Now, a lot of states are changing that where emergency medical responders can actually operate an ambulance because we're starting to see a downtick as far as how many individuals are actually trained within the EMS system. Next, we have an advanced EMT. So they're trained to the capabilities of the EMT, but oftentimes they have additional interventions that they can actually perform based on their certification, such as medication administration and some protocols for IV access and fluid boluses. And then the highest level of training is going to be the paramedic. And so the paramedic is going to be able to perform all the interventions that the EMR, EMT, advanced EMT can do, but they have higher levels of training as far as cardiology, medication administration, advanced airway management. So here's our scene. We have a patient, we have first responders arrive on scene, and again, they're going to mitigate that scene and start performing immediate life-threatening emergencies. We then have a basic life support ambulance that shows up. They're going to be able to perform those EMT basic level skills, and if it exceeds their scope of practice, then they need advanced life support to show up. So an advanced life support ambulance or a fly vehicle may arrive with a paramedic in order to do those advanced level certification interventions. So traits of a good EMT, physical traits and personal traits. So I want you guys to think about this. What would be some good physical traits? What would be some good personal traits? And then we're actually going to talk about this on Thursday as a group discussion. Education. So with continuing education, there's a couple of different routes that we can do. There are refresher training they can do. So those refresher trainings range in between 20 to 30 hours. Most EMTs need to have 40 hours of continuing education in order to renew their license and certification. How we actually get this continuing education oftentimes is going to be dependent upon where you actually become a provider. So some larger EMS organizations, they're going to be able to do all of their continuing education in-house. Other smaller EMS organizations, they oftentimes will contract with a local EMS education service or a technical college to actually come in and provide that training for them. Again, I mentioned the National Registry certifications and licenses. You're going to have to renew both of these every 2 years. Most of the time, the components necessary are exactly the same. So you're going to perform your 40 hours of continuing education. You'll fill out an application for the NREMT. You'll fill out an application for the state license, and as a result, you will get both of those renewed. Now, different ways you can get that continuing education. Conferences are a great way to get continuing education hours in our specific area. The Arrowhead EMS Association puts on a really nice conference every year. I highly recommend that you go to it. Usually it's in January, and it's about a 3-day long conference. Other areas, quarterly training or in-house training. So oftentimes your training officer for your specific organization or your medical director will put on an in-house training, and oftentimes this specifically relates to your protocols and your guidelines for your service. Also, very popular thing that's coming out is online training for ease. And so there's a number of different companies that actually build online components that you can actually take. A lot of them are actually free. So Boundtree Medical University, EMS One, EMS World, all of these online formats you can actually get as far as getting continuing education hours. And it's good to stay up on medicine because medicine evolves and changes so fast. So next we're going to look at quality improvement, because as professionals within the EMS world, we have to continuously improve in order to provide the best possible patient care. And so this is where QI and QA, which stands for quality assurance, comes into place. So the definition of quality improvement is going to be a process of continuous self-review with the purpose of identifying and correcting aspects of the system that require improvement. How this is flagged is oftentimes this is going to be flagged within your reporting software. So for any time that there's a cardiac arrest or a major trauma or a difficulty breathing, that will get flagged, and your QA/QI specialist within your organization will be notified, and your medical director will be notified. They'll go through your report, They'll see, maybe areas that you did really well, areas that need improvement, and as a result, that will build your professional characteristic. And then on that next cardiac arrest call or that next trauma call, you're going to be able to do a little bit better. And so a lot of people get upset about being QA'd, QI'd because they think they're being attacked, and that's not the case at all. It's a continuous improvement of the organization and of the EMS professional. So what you can do as far as quality improvement as an EMT is document the best to your ability. The best reports that I see and I review are ones that I can read the narrative and read that report and basically put myself on that scene. We can also be involved in the quality process. So maybe we'll get a few years underneath our belt, and then we can actually get a role in reviewing people's documentation, reviewing people's calls, or being a field training officer and guiding new EMS professionals into that process. Maintaining your equipment, making sure that it's in a ready state. Another thing that will always get QA, QI'd is if there's an equipment malfunction. And then continuing education. Now, medical direction, I'm going to reestablish this because this is a very important concept within EMS that oftentimes gets overshadowed. So again, the definition of our medical director is going to be a physician who assumes the ultimate responsibility of the patient care aspects of the EMS system. So you're going to have a boss, a CEO, a chief, what have you, but the ultimate responsible individual for an EMS organization is going to be the medical director for that operation. What the medical director is going to do is they're going to provide medical direction. So the definition of this is going to be oversight of that patient care aspect of an EMS system. With that, they're going to develop protocols and guidelines. So protocols are basically going to be a book of what you should do on certain calls depending on the chief complaint and what you see on scene. So these are lists of steps and assessments, interventions to be taken in different situations. So you're going to have a cardiac arrest protocol. That protocol is going to say if your patient is in cardiac arrest, what you should do is immediately perform chest compressions, assist ventilations, maybe insert an advanced airway. And again, it's kind of like a cookbook recipe as far as what you should do. Next, we have a designated agent. So this is going to be us. We're EMS professionals that are authorized to work under that medical director. Then we have standing orders, offline medical direction, and online medical direction. So our standing orders are very similar to that of our protocols. It's a policy issued by the medical director that authorizes us to perform certain skills in certain situations. Now within our standing orders, they can either be offline medical direction or online medical direction. So offline medical direction are standing orders that we can do without the guidance of medical control. So if our protocols say that we can perform chest compressions on a patient who's in cardiac arrest, and we don't have to call medical direction or do that intervention, then that would be offline. Now in online, those are going to be orders directly given to an EMT or an EMS provider by a physician. So same scenario, we have a patient in cardiac arrest, and maybe in our protocols and guidelines, it states that we need to call the doctor before we insert an advanced airway. So that would be online medical direction because I actually have to talk to that physician prior to actually doing that intervention. Different ways that we can actually contact that medical director is our portable radios. Depending on your organization, maybe that medical director likes to be contacted directly. So we don't know if he's at work or if he's at home, so we might have to use a cell phone. Most organizations are going to operate in the fact that they call whatever hospital that patient is actually going to be going to. So this individual would call, let's say we're transporting to Essentia Health St. Mary's Duluth. They would call St. Mary's Duluth, and actually talk to an ER physician there and get guidance and orders from them. Now diving deeper into public health, big thing right now in the evolution of EMS is prevention. So injury prevention for geriatrics, injury prevention for youth. A couple of ways that we're going to be doing this is, let's say we get called for a lift assist. We get there for a lift assist and we notice a bunch of throw rugs on that patient's floor. Maybe advise them not to have all those throw rugs as far as trip hazards. Injury prevention for the youth. A lot of organizations have multiple bike helmets stocked inside their ambulance. They're driving down the road. They see a kid out on a bike and he doesn't have a helmet, and they're going to pull over and actually provide a helmet for them. Public vaccination programs. A lot of different EMS organizations actually do flu shots in different areas. Disease surveillance. Based on our documentation and our records, if we're just starting to see the same thing come up time and time again, the national and state systems actually look at our reports and they'll get flagged if we start to have more and more calls with a specific disease. So they perform surveillance, and then that's actually going to be, notified to the CDC. And then community EMTs and paramedics. This is kind of the wave of the future too, where we'll go out to individuals' homes after they are discharged from the hospital and make sure that they're taking their medications properly, their vital signs are coming back okay, and then also guiding them through their treatment plan that was depicted by the healthcare facility and physician that they saw. All right, a lot of information in chapter 1 as far as the introduction in emergency medical care. So make sure that you review that, a lot of good information, and I will see you next time. Thanks.